Hello and welcome to this year's Symposium on Alzheimer's disease. As so many other things have gone virtual this year, this talk will be no exception. I have been very pleased in my own practice about how well telehealth has worked and served my patients, and I hope that this format serves our purposes today as well. For those of you that I've not had the privilege of meeting, I'm Dr. Mark Burns, Adjunct Professor of Psychiatry at UT Health and a psychiatric consultant here to Eden Hill. We're coming to you right now from the Eden Hill Chapel. This is a spot, of course, that's near and dear to my heart. I think I'm in my 22nd year of consulting to Eden Hill and training resident physicians, medical students, nurse practitioner students, and geriatric psychiatry fellows here at Eden Hill. It's truly a special place. So as with any lecture given by a faculty person in an academic setting, this slide indicates my disclosure. And as you can see here, I have no disclosures to make other than the fact that I am a paid consultant to Eden Hill. However, Eden Hill did not provide financial support to me for this talk today. It's part of my consulting to Eden Hill, and I'm happy to be providing this service. And this is, I believe, our second annual symposium, so look forward, hopefully, to being with you next year and hopefully in person. This slide illustrates something I think we're all familiar with, my life broken down into segments. As you can see, sleeping, working, eating, and then a large chunk just looking for things that I had just a minute ago. A perfect segue into our topic today. We're going to look at some of the early signs and symptoms of dementing illness in this slide. Most of you will be familiar with these. Of course, the central feature of dementia is loss of memory. In fact, dementia is taken from the Latin which literally means out of one's mind. And we'll talk a little bit about that first patient with Alzheimer's disease that was described in 1906. And literally she was having symptoms of really severe dementia and paranoia, etc. So for many years, dementia has been known as a syndrome that affects not only memory, but behavior and also perceptions. Also, we can see challenges in planning or solving problems, difficulty completing familiar tasks. So, for example, an accountant who may be unable to balance his or her checkbook, that would be a warning sign of dementing illness, this loss of function. Confusion with time or place, that usually occurs later in the disease. Trouble understanding visual images and spatial relationships. We'll talk more about that when it comes to testing. Problems with speaking, writing, judgment difficulties, and then also social withdrawal, apathy, changes in mood and personality. All of these symptoms can be present in dementia. Now, what's important to know is that dementia is really a term, think of it like a large umbrella, maybe a circus tent. And underneath that tent, there are many causes of dementia. We'll talk a little bit about Alzheimer's disease in a moment, but I want to talk about some of the other causes of dementia that fill up that virtual circus tent. This is organized in mnemonic form. I use this as a teaching tool for residents and fellows. Deficiencies of vitamins is the D, the first D. So we know that B12 deficiency, folic acid deficiency can cause difficulty with memory. Also degenerative diseases, and of course here Alzheimer's comes into play. Things like progressive supranuclear palsy, Parkinson's disease, Lewy body dementia, even multiple sclerosis can cause dementia. And then endocrine diseases, that's the E in this mnemonic. Things like problems with the thyroid gland or the adrenal glands. And then M is for metabolic diseases. Things like low blood sodium, low blood sugar, low blood oxygen, problems with calcium metabolism, and the list goes on. And then the next E is for exogenous poisoning. There are many elements, compounds that can cause dementing illness. Now, these are not very common causes any longer because we know about these and have taken certain public health measures. But for example, in the 17th and 18th centuries, and even into the 19th century really, and perhaps most prominently there was an illness known as basically Mad Hatter's syndrome. Mercury was used in the production of hats at that time. And so these poor individuals who had no other way to make a living would develop dementia due to mercury poisoning. There are other metals that can cause dementia like arsenic, lead, etc. And then neoplasms is N in the mnemonic, and that just is a medical term for a brain tumor essentially. Multiple different kinds of brain tumors can cause dementing illness. Trauma is the T here, and of course these days we hear a lot about chronic traumatic encephalopathy, or CTE, that is afflicting football players, devastating disease caused by repetitive traumas. Infectious diseases can also cause dementing illness. Things like chronic meningitis or Jakob-Creutzfeldt disease, also known as mad cow disease. And then, of course, arteries, when they are blocked, and these are the vascular causes of dementia, can cause problems with memory and these other core features of dementing illness. But this particular slide shows you really what things look like under that virtual circus tent, or in this case, a large pie. And you can see that the pie is overwhelmingly occupied by Alzheimer's disease, abbreviated AD here. And then when you take conditions combined with Alzheimer's disease, such as Lewy body dementia or diffuse Lewy body dementia, as it's indicated here, DLB, and then look at Lewy body dementia and vascular dementia combined perhaps with Alzheimer's disease or by themselves, now you've made up, probably 95% of this pie. So these other causes that I've mentioned are really fairly rare causes of dementing illness. Well, I'm often asked by audiences, how do we as physicians discover the cause? Since there are so many causes of dementing illness, what is it that we do to figure out what exactly the etiology is? Well, first of all, we take a very careful history, and that's where so many of you in the audience come in handy, because you're here obviously because you have an interest in dementing illness. Many of you probably have a loved one afflicted with this illness, or you work in a healthcare setting where you serve a lot of dementia patients. So we as geriatric psychiatrists get a lot of our history about our patients from family and friends or healthcare providers, because often when the illness is diagnosed, memory is impaired so much that it's hard to get a good history from the patient. After a history, we conduct a thorough physical examination, and that includes a neurological examination. And part of that neurological examination is a cognitive assessment. Really looks at multiple cognitive domains. These are things like memory, reasoning, judgment, and we'll talk about some of those tests in just a little bit. And then we also look at patients' functional ability. Can someone continue to take care of their basic activities of daily living? Bathing, dressing, ambulating, toileting, and transferring, and can this patient feed him or herself? And of course, prior to losing those activities of daily living, we know that patients will begin to have difficulty with driving, or perhaps preparing meals, or handling personal finances. Finally, we get some laboratory tests, and this slide indicates a number of those tests, everything from a complete blood count to a CT or MRI scan of the brain. And then there are some optional studies that we may get depending upon the patient's presentation, things like an EEG or an analysis of patient's cerebrospinal fluid. We may even check for some of those heavy metals that I mentioned earlier if we have a concern about poisoning. When we talk about the cognitive assessment tools, this slide lists some of the more popular ones. The Montreal Cognitive Assessment is now probably the most popular worldwide. It has multiple different versions, a version for the blind, multiple languages. And so this tests for a variety of the issues I mentioned earlier. For example, one of the first items is what's called a trails test. And so the patient is asked to complete a pattern. They're asked to start with the number 1 and then connect the number 1 to the letter A and then connect A to 2. So you can give yourself a quick trails test right now and complete the pattern 1A, 2B, 3C, and so on. And you'll see patients with dementing illness, they'll lose track fairly quickly. They'll just start to connect numbers or maybe letters in sequence without going back and forth between numbers and letters. The St. Louis University Mental State is another test, again, not used quite as often anymore. But simple clock drawing can also be used as a screening tool, asking someone to remember 3 to 5 items and then have them draw a clock. And then, of course, while they're drawing a clock, they may forget those 3 to 5 items, and we'll pick that up. And that is a warning sign of dementing illness as well. In fact, here's a clock drawing test here, and you can see that the patient there in the my upper left here, probably upper left on the screen as well. You can see this patient's drawn an accurate clock, showing a good time here. The hands are in the right spot. But as the patient begins to progress, you can see that the clock becomes more disorganized. The time that's supposed to be indicated here is 2:45. And what you see there underneath the clock with the 8 beneath it is you see a hand drawn to the 2, and then you see they've drawn a hand sort of between the 4 and 5. So that person has lost their abstract reasoning ability. They no longer understand the concept that 9 represents 45 minutes. And that is called an executive function problem or a frontal lobe problem. This part of the brain here controls that higher reasoning. And then at the very end, you see someone has started to write clock down. They've only got the CL, and then they put in a 9 and they write a 45 there. So very, very severely impaired patient here. Well, so this is an overview that I've given you of dementia, which we now call major neurocognitive disorder. And now we're going to drill down specifically on the most common cause of dementing illness, and that's Alzheimer's disease. Before we get started, I wanted to share with you something that I ran across which illustrates humorously the challenge of communicating things accurately to an Alzheimer's patient. So a nurse wrote, during a recent fire drill, she was closing doors to patients' rooms. And remember, this is a fire drill. And so an 86-year-old patient happened to be talking on the phone when the nurse reached her room. And as the nurse explained to her what's going on, the nurse started to close the door. She heard this patient say, don't worry, sweetheart. There's a fire here in the hospital, and a sweet little nurse came in to lock me in my room. So you get an idea about the challenge of trying to communicate with someone who can only receive and decode part of that message. Let's talk a little bit about Alzheimer's disease and Dr. Alzheimer. So he is a German neuropathologist and described this illness in 1907, 1906 or 1907, depending upon who you talk to. And what he noticed in a 51-year-old patient, so really someone quite young, this woman had early onset Alzheimer's disease. The youngest patient I've diagnosed in my practice is actually 48 years of age. Devastating to develop Alzheimer's at that age, and certainly at any age, really. But Dr. Alzheimer saw, when he looked under the microscope after this unfortunate woman passed away, he looked at her brain under a microscope, and he saw that there were these plaques. And then he also saw there were tangles. And these plaques and tangles are still what we call the central neuropathological feature of Alzheimer's disease all these years later, over 100 years ago. And we, of course, still owe a tremendous debt to Dr. Alzheimer's and his research. This slide is a little bit dated. It talks about Alzheimer's disease as a global epidemic. Of course, we're in the midst of a global pandemic. When you consider, of course, Alzheimer's disease worldwide, at least 44 million people are living with dementing illness. In the United States, that's probably around 5 million or more. And this slide again is dated. The projections are a little outdated as well. In 2013, it was estimated that the United States would spend about $203 billion, and this could rise up to $1.2 trillion by 2050. Someone develops Alzheimer's disease about every 67 seconds in the United States. And by 2030, it's estimated that about 76 million people could be living with Alzheimer's disease. So this is a huge and looming public health crisis headed our way. Well, what are some of the risk factors for Alzheimer's disease? And really, I should say not only Alzheimer's disease, but really any dementing illness. Advancing age, certainly. We know that at age 60, only about 1% of individuals have a dementing illness. At 65, that's 2%. At 70, it's 4%. At 75, it's 8%. You see the pattern there. It doubles about every 5 years, so that by the time someone reaches his or her 90s, that risk can be 50% or greater. If there's a family history of dementing illness, that can increase risk. Many of you have probably heard about what's called the ApoE4 genotype, and that just means if you have 2 copies of the ApoE4 gene, you have a significantly higher risk of Alzheimer's disease. But those risk factors can be modified, and we'll talk about that in a little bit. Being overweight and associated insulin resistance, high blood sugar, that's a risk factor. Vascular disease, high cholesterol, high triglycerides, problems with blood pressure, increased blood pressure, and certain inflammatory markers. We're hearing a lot about inflammatory markers right now as a reason that some people with COVID have a really terrible and rapid downhill course, because the immune system pumps out things called cytokines and other inflammatory chemicals that then cause great tissue damage. So we know that brain inflammation is one way that Alzheimer's disease may be mediated. Down syndrome also can cause dementing illness. In fact, I often ask audiences what percentage of Down syndrome patients will develop Alzheimer's disease. So you can take a moment and see if you can guess the percentage. But depending upon the study you look at, probably somewhere between 75 and 100%. Really, if Down syndrome patients live long enough, the vast majority of them develop Alzheimer's disease. And then we've talked about traumatic brain injury, of course, as a risk factor as well. And moving on, this looks at the diagnostic criteria for Alzheimer's disease. I will summarize these by saying there are 4 A's and an E. Now these have been updated a little bit, but I think for our purposes they really still define the core characteristics of Alzheimer's disease. The first one is amnesia. Well, that's easy, right? Memory loss. So that's the first A, amnesia, inability to remember things that one really ought to remember. The next one is aphasia. And aphasia just means language difficulty. Can be understanding language, producing language, both of those things. And of course, you know, that presents really tremendous challenges for caregivers in managing dementia. How do you communicate with someone who has a dementing illness? You know, late in the stage, or I should say late in the illness, late stage dementia, I often liken it to someone dropping you in a foreign country and you have no idea where you are and you don't speak the language and you're trying to survive in this situation where you're completely disoriented and you can't communicate with individuals. Agnosia is another neuropathological feature, I should say, clinical neurological feature, that just means you can't recognize objects or their appropriate uses. For example, someone with Alzheimer's disease that's fairly advanced, they may try to use a fork as a comb. The tines on the fork remind them of the teeth on the comb, and they don't understand the difference between those objects, and they can't recognize them. Apraxia just means an inability to perform certain complex movements despite not being paralyzed. For example, it's really easy for me, even while giving a lecture, to unbutton and then button my lab coat. But someone with dementing illness would have a great deal of difficulty doing that because he or she no longer can perform a task like that, or tying one's shoe, for example. That also would be very difficult. And again, it's not that that person is paralyzed. They have the use of their hands. They have the use of their feet, but they may have great difficulty feeling confident walking or getting up out of a chair, sitting down, because that's a complex series of movements that to us comes naturally. But when you're losing those nerve cell connections that are telling you how to do that, then you're truly lost. The last part of this way to remember Alzheimer's disease is E. It's an E, 4 A's and an E, and that stands for executive dysfunction, what we talked about earlier, inability to perform certain complex tasks. Prepare a meal, serve a meal, driving, balancing a checkbook, those kinds of things. All right, so this is just an updated version of those challenges that I mentioned, and with a couple of caveats, that there really has to be a decline from a previous level of performance as well. And we have to have, of course, information from a caregiver or other informant that's allowed us to know that there's that decline in function. All right, so how does this disease progress? Before we jump into that, I'll share another story that I ran across. A couple in their 90s are having some problems with memory, and during a checkup, their doctor reports you're physically okay, but that you may want to start writing some things down because you're having difficulty with your memory. And so one evening, the husband gets up, he's going to the kitchen and asks his wife, well, sweetheart, would you like anything while I'm in the kitchen? And she says, well, you know, I would love a bowl of ice cream. And come to think of it, I'd like some strawberries on top. Now, maybe you should write this down because the doctor said, you know, that we're having some memory troubles. And husband says, look, I got it. You want a bowl of ice cream with strawberries. And then his wife adds, well, maybe some whipped cream would be nice as well. And so he goes, now you sure you don't need to write this down? And he's, I've got it. He's a little bit upset, thinking, you know, this is easy. So he disappears into the kitchen. About 20 minutes later, okay, he comes out and he hands his wife a plate of bacon and eggs. And she looks at that for a moment and then looks up and said, where's my toast? So I think it's important for all of us just to take a moment and to realize that we have to sometimes see the humor in situations as well. Obviously, Alzheimer's is a serious illness, correct? It can be absolutely devastating. But as the disease progresses, as you see here in this slide, there can be actually some grace in that. And an actual case example I'll share with you that a woman had terrible losses in her life. Loss of status and home and business during wartime, loss of a beloved husband who had sort of been her knight in shining armor in the wake of this terrible catastrophe of World War II, and then lost a son, and was just absolutely grief-stricken every session that my team and I had with her. And as her illness progressed, she forgot about all those losses. And she would instead ask, okay, well, when's my husband coming to get me, and when will my son be here? And the staff was able to work with her through that, not tell her that she had these losses, but to explain to her, well, look, before they get here, why don't you join us for dinner and some games, etc. And this, of course, would replay multiple times during the day, but no longer was she tearful and grief-stricken about all of these losses. In fact, she at one point then again began asking about her parents, even though she was, of course, in her 80s, about moving back to her home country to be with her parents, and would smile and reminisce about that, and staff would use that as an opportunity to reminisce with her. So again, in the midst of this devastating disease, there's some grace, and if we can stop and pause and see that, and also sometimes see the humor, and in fact enjoy humor and laughter with our loved ones who are afflicted by this illness, we're all the better for it. So to look here at this slide, again, mild, moderate, severe dementia, you see it starts off with memory loss, and that is actually even before the diagnosis. We're unfortunately not great at picking up very, very early dementing illness, so that maybe 10, 15 years even before the diagnosis, there have been some subtle changes. When we make the diagnosis, again, it may have been present in the brain for 10, 15, 20 years. We see then a gradual loss of independence. Towards the moderate stage of the disease, you can see behavioral problems, and it's around this time also that many patients are placed in facilities because of behavior problems or loss of the ability to take care of their toileting needs, for example. That's a very difficult thing to manage at home. And this just reiterates that fact, a progressive loss of activities in daily living, going from mild, where you can still use the telephone, to moderate, where you need help with grooming, and then towards the severe stage of the disease where people need help with eating. Average time of diagnosis to death is about 10 years or so. This particular group of slides looks at another way to assess people with dementing illness called the functional assessment and staging, and this is rated from 1 to 7. Again, similar to what I've just talked about. Stage 1, really, we can't see the disease. It's there in the brain, but we don't know it's there because we're not good enough yet at measuring it. Stage 2, there's some memory loss. It's reported by the patient. Stage 3, we can certainly see it on testing. Stage 4, complex activities are lost, like, again, planning a dinner party, for example. Stage 5, individuals start having difficulty with dressing. Stage 6, that gets worse, and now toileting is an issue. By stage 7, individuals can no longer speak, they can't talk, they can't even hold their head up by the end of stage 7. And from about stage 7D on, we're really seriously considering a referral to hospice at that point. Well, so a lot of sobering news, if you will, about dementia that we've talked about before, sprinkled in with a bit of humor. Now let's talk about some hopeful news, strategies that may help reduce the risk of Alzheimer's disease, of dementia, or what we call major neurocognitive disorder. So exercise. Studies show very clearly that exercise is very beneficial. Meredith Patterson has already spoken to you a great deal about that. She's probably let you know that there's a 50% reduction in the risk, according to one study, for people who just walk a mile a day, 6 days a week. Incredible that we can see that sort of reduction in risk. Eating a Mediterranean diet, also known as the MIND diet. That's a specific kind of Mediterranean diet. Essentially, you eat a salad every day, make sure that you have 2 to 3 other healthy vegetable servings per day. If you eat an animal, make sure it can swim, cluck, or gobble. And then also eat beans, tree nuts, blueberries are very powerful antioxidant compounds. When you cook, use olive oil as the cooking oil. Brain training is getting mixed reviews. It depends on the type of brain training, the type of brain exercises. We're still finding more out about that. Certainly avoiding head trauma is very important. So, of course, we encourage people to wear seat belts, wear head protection if they're riding a bike, rock climbing, skiing, etc. And then maintaining strong social connections is also vitally important. And of course, that's been a challenge for some people during the age of COVID. That's why I'm not a fan of the term social distancing. We want to be physically distant. We want to be within a safe physical distance, but we don't want to be socially distant. You can have conversations via FaceTime or Google Duo or Zoom. You can be social and still maintain appropriate physical distance to protect you from COVID. So when it comes to exercise, the doctor here explained, of course, the handle on your recliner does not qualify as an exercise machine. It's a start. It's a start. And I encourage people to do just that. Start with as little as 5 minutes of walking a day, and then make that a habit day to day, and then you can expand it gradually. This shows actually some of the positive effects on the brain of walking. And you can see here really something quite remarkable. You see these areas of the brain that are really lighting up with these colors. And guess what? These are the areas of the brain that are important for memory, for attention, for concentration, for higher reasoning. So you can actually see improved blood flow, and not only that, you can actually increase the size of your brain measurably by exercise. Really, just an awing finding. We had no idea 20, 30 years ago that was possible, but you can create these new connections. I sometimes use the analogy, if my finger here, let's say, there may be 10 neurons there. Under the influence of walking, you sprout new connections, so you build these additional bridges. In fact, we call that arborization. Just like the tree growing branches, you're growing these connections. Just phenomenal. My doctor told me to start exercise program very gradually. Today I drove past a store that sells sweatpants. Again, you got to start somewhere with your exercise program. Well, so we've talked about these non-medication approaches to dementing illness. Let's talk about what we have available in terms of FDA-approved drugs. And sadly enough, I could have given this same talk 10, perhaps as long as 15 years ago, and it would look very similar. We just have not had numbers of new compounds. I know all of you hear news reports about something that's promising in the treatment of dementing illness, and then subsequent studies show that it hasn't had the kind of effect that we want. There are numbers of things in the pipeline. Our time today doesn't really allow for that, but research is ongoing. We want to be, I think, robust about funding that research through our support of the Alzheimer's Association, and of course the National Institutes of Health also is working hard. So these medications include donepezil, which is also called Aricept, galantamine, called Remenil, memantine, called Namenda, and ribostigmine, called Exelon. That last one is available as a patch. So if someone is resistant to taking medications, it can be put on their skin and rotated around so that they can get the benefit of the medication. Because, so many people with Alzheimer's disease and other dementing illnesses say, I don't need to take any medicine, nothing's wrong with me. But you can actually put this patch on and they can get benefit. These medications, most of them increase levels of a chemical called acetylcholine, which helps nerve cells communicate and form memories. They're not cures by any means. If we're lucky, they can give someone the memory they may have had 2 years ago. That's about the best we can do with our medications. Mementing is a little bit different. I use the analogy sometimes that what mementing does, it helps to preserve those nerve cells that are just on the edge of dying or blinking off, if you will. Think of those nerve cells as a